Hello, thank you for showing an interest in our PGY1 pharmacy residency program. My name is Krista McElray, and I am the PGY1 residency program director. I also wear a lot of other hats within the UW health system. And I just wanted to take a minute to welcome you all. We had a very impressive pool of candidates this year, and we're really excited to share a little bit more about what we have to offer here in the PGY1 program. I'll start out by sharing a little bit about my background. I have moved around quite a bit, up at least through residency and through my training. I started out at Ohio State, where I did my school of pharmacy training, and then spent 2 years down at Medical University of South Carolina in Charleston, where I did a PGY1 and PGY2 in internal medicine. If you fast forward to what my life looks like now, I've been in Madison now for almost 5 years. And Madison's really an awesome place to live. I feel like there's a lot to do here, lots of outdoor activities. We very much like it here a lot. Some other things just about me to share, and looking forward to getting to know you all a little better too. I did become a new mom this past year, so we've become a family of 3. This is actually a picture of my son headed off to daycare on his very first day of daycare. He's about 3 months old. I've got 2 puppies right here. If I get to make the slides, I'm going to throw in a cute picture of my dogs. Here's a picture of Madison Night Market, which is a fun event that they put on in downtown Madison. That's kind of like a little bit of a farmer's market-like feel. This particular one had a concert that was right there by the Capitol as well. Here's a summary of what I'll go through in this presentation. I'm going to talk just a little bit about what the interview day entails. It's going to be obviously different this year because there's a couple of these videos that you watch ahead of time. And I'll talk a little bit about what I call multiple mini interviews, or what those different sections of the day look like. Then I will briefly touch on some highlights of UW Health, talk about what pharmacy practice looks like here at UW, and I'm going to spend a good chunk of my time talking about just the PGY1 program in general, which I think is what you all are most interested in. And then at the end I have some of my favorite things in Madison to talk about, as well as some fun photos of our residents. What are multiple mini interviews? So what I mean by this, and this is what I call, but this is your preceptor interaction that you have, the clinical case that you have to do, and the mock provider interaction. So what I think about these as being is that they are work products. So essentially we are giving you a chance to test out the waters of what it would be like to be a pharmacist and a pharmacy resident here. So we're giving you some mock examples of what that is going to entail. And then we are able to collect some data on how well you do in those particular types of situations. And everybody's getting a very standardized approach. What this does is it helps us to reduce bias from comparing candidate to candidate, and gives us a good gauge of your entering skill set. Now, if some of this seems unfamiliar to you, you feel like you didn't know the clinical case, that's okay. One thing that I feel confident that I can always teach someone is a clinical skill set. A lot of it is how you approach the situation and kind of how you work your way through. Just be honest with us on what you would do if you needed a particular resource or something along those lines. Just be very candid. I also encourage you to use it as an opportunity to get to know those preceptors that are running those various scenarios. I think that is a good opportunity for you to get to know those folks that you'll be working with as well if you decide to come here. This is my my brag slide about how great UW Health is. I think it highlights some of the reasons why I decided to come here, and also hopefully some of these things really resonate with you. Some things that I will specifically highlight off of this slide are We are a fairly large transplant center, so if transplant is something that you want to get more experience in, we'll kind of force it on you because transplant is one of the required rotations. And we did recently get magnet recognized, so you can feel confident in coming here that you're working alongside nursing colleagues that are really practicing at the top of their licenses as well. For those of you that don't know, Epic, the electronic medical record software that's used many places around the country, their headquarters is about 20 minutes from here. Epic headquarters is a pretty crazy place. It's a very cool facility, and most years we are actually able to set up visits to go send a group of residents there. I got to go a couple years ago. It's a very cool facility. We got a tour. They have slides inside. The different buildings are themed. If you do opt to move here from not in the Madison area and you start to talk to people in the community, almost everyone will ask you if you're moving here to work for Epic because they are such a big pull in the Madison area. With that, we do utilize Epic to a very high level. So we have this Stage 7 Analytics Award. We're really using Epic to the most of its ability and have been for quite a while. Also, we tend to be a destination for cancer care, have received the IDSA Antimicrobial Steward Center of Excellence Award, so great place to get some antimicrobial stewardship training as well, and that tends to be an elective that most residents choose to take as well. Now I'll move into talking a little bit about pharmacy practice at UW Health. If you are to pick up anything on your interviews, I think that the thing that you should really try to figure out and gauge your questions around is what it means to be a pharmacist at that particular institution. And that really gets at what is the pharmacy practice model. So I'm going to do my best to explain what our model is, and hopefully you can pick up some tips and tricks on how do you figure out what this is at other institutions too, because it's really hard. Probably the best question around figuring this out is to ask, what does your typical day look like? What does a typical day for a pharmacy resident look like? That can help you to understand what the roles and responsibilities are. So what is a pharmacy practice model? So it really describes how a pharmacy department utilizes their resources to provide their patient care services. It includes how pharmacists practice and care for patients, how the technicians are involved or leveraged in that care, and also touches on automation and technology and how that's utilized. And as I mentioned, really one of those most important things to figure out on your interviews. If you're interested in this and want to learn more, I really encourage you to pull this AJHP publication. It's a little older now, but I think it does a great job of explaining what the different practice models are like and where practice is really headed. So we will mostly focus kind of on explaining the difference between a clinical specialist and an integrated model. For completeness, I'll briefly touch on a drug distribution centered model. So a drug distribution centered model is mostly distributive and has limited clinical services. So this would be somewhere where you don't have pharmacists on the floor, they aren't rounding with teams of physicians. Really, your pharmacist team and pharmacy department is more focused on just getting drug to patient. A clinical specialist model has more separate distributive and clinical specialist roles. So often you have pharmacists that are order verifying pharmacists and clinical specialist pharmacists, and they have very different roles and responsibilities. Those distributive pharmacists are really responsible for the drug product, are responsible for verifying the order for clinical appropriateness. An integrated model is more of a clinical generalist model, which kind of melds those two together and has limited differentiation in roles. And all of the pharmacists do almost all do both the clinical and distributive responsibilities. And then you have a comprehensive model. And my argument would be that this is kind of where we fall. We are that combination of integrated and clinical specialists. So The way I like to describe it is to be a pharmacist at UW, and we hold everyone in kind of a clinical pharmacist title, but they really function at the level of a clinical specialist. The pharmacist is really a one-stop shop. So one pharmacist is responsible, let's say for, typically if I'm staffing on a medicine service for a day, I would be responsible for 2 different teams, but I do all the order verification. I am the same person that's doing the admission medrec, the discharge medrec, the orders that are verified throughout the day. I'm the one person that is contacting the medical team to make sure that those things are going correctly. Helps to make sure that lines don't get crossed. A lot of my training grew up in a clinical specialist model, and one of my frustrations that I would have in that particular model would be that I would recommend something to my team on rounds, ask them to put in the orders, and then it would be a pharmacist on my team within the pharmacy department that would then page that provider about a question they had with the order, which I think just makes the communication a challenge, and sometimes isn't always the best look for pharmacy to have different pharmacists that potentially disagree on the way a certain thing should be done. I think that often there's multiple solutions to a problem. This allows you to really be, this comprehensive model allows you to be the person that comes up with that solution. Getting back to the publication that I mentioned before. So if you're looking at our pharmacy department here, this is a table that I pulled out of that. You're probably looking at larger hospitals. So if you applied here at UW, you're kind of thinking in that 400 to 600 bed range. So, or 600 plus bed range. So here in that gray box, that's where you focus on those 2 lines. What this shows is where the future direction of what a pharmacy practice model at a given institution, pharmacy directors were polled on like where their department is headed. So the current structure is outlined here. So we've got about, let's say 55% are in that patient-centered integrated, and around 35% are more clinical specialists. So if you fast forward here, you can see that there's really a growing trend of this patient-centered integrated model, where a lot of these hospital systems are moving towards, here in the blue box, the patient-centered integrated, and fewer are planning to stay in a clinical specialist-centered model. So what does this really mean for you? I think that I really encourage, wherever you decide to complete residency, you think about what type of future career you see for yourself and what the job market is going to be like. I think that it's important that you learn about order verification responsibilities and really how to be a pharmacist in a lot of different models. So to me, what this means is about, I don't know, probably 3/4 of the jobs that are going to be out there in the future are going to be at facilities that have more of an integrated model where a pharmacist has more roles and responsibilities. So really just encourage you all to keep that in mind as you decide where you train, and also the types of opportunities that you pursue when you start your PGY1 program, to make sure that you're trained in ways that prepare you for future practice. So as I mentioned before and alluded to, we really fall into this more comprehensive model that's that combination of integrated and clinical specialists. Some may argue that we fall more into that integrated model, but we do have separate teams where you have the cardiology pharmacists, internal medicine pharmacists, critical care pharmacists that are functioning at that level of a specialist. They just do all of the things related to the care of that patient, with the exception of like preparing the physical drug product and delivering it to the unit. So there we go, comprehensive. So within our comprehensive pharmacy practice model, these are some of the things that I'd really like to highlight. So pharmacists really have a role in interdisciplinary patient care rounds. I would say that our frontline pharmacists mostly focus on kind of coordination of care or discharge rounds. I have very strong relationships and interact often, especially on when I staff on internal medicine, with our case managers and social workers to help stay in the know on what's happening in terms of those transitions of care, where patients are going to go when they leave, how we're going to help make that transition smooth. When it comes to transitions of care, we do and have been for many years a medication history and formal pharmacist checked medication reconciliation process on 100% of patients that come into our facility. We really see that as, how can you know how a patient's medications have been managed unless they you have a good med list when the patient initially comes in. We also, it's a hard stop within our system that a pharmacist completes discharge medication reconciliation for every single patient. So I would keep that in mind. It's a huge responsibility to take on 100% of those, what we call admits and discharges. It tends to be a bulk of your day, but it I find to be probably the most clinically important thing that I do. I have caught things where a patient, some really big items, where things like a patient comes in and is admitted with a pulmonary embolism, and they get all set up to leave. The discharge med rec is completed. The patient's ready to go. Pharmacist comes in and checks it, and there was no oral anticoagulant on the discharge medication list. So obviously that's a huge intervention that we can make. Now, most of the time those kinds of things are there, and the pharmacist is helping to make sure that it's the cost-effective choice. We do have resources in place to help you with that. Making sure that it's the right choice for that patient. But we almost always have recommendations or help that we can provide to make sure that the antibiotic plans, the diabetes management plans, all those things are set up appropriately. We do have a pharmacy-run medication orders management team that you can reach out to get various orders fixed for a patient. So not that many need to be fixed, but I often have emailed when something just didn't look right to me, emailed our medication management team, and they are able to get things fixed within the Epic interface if something needed to be fixed, or really just if something could be honed to be better utilized by the end user. We do have a lot of delegated authority at UW, and what I mean by that is that we have a lot of protocols and guidelines in place that have established things that a pharmacist can automatically do without the intervention of a physician. So some of those things are, and I'll highlight some of the specifics, but pharmacists can renally dose adjust all medications for all patients based off of their renal function. Not all medications, but the vast majority. If there's gray area, sometimes they have to have intervention from a physician as well, just to make sure that it makes sense to them. The other things that come to mind in terms of delegated authority would be looking at refills at the time of discharge. So if a patient says, hey, I'm out of my lisinopril, a pharmacist can, for anything that's not a controlled substance, can provide a 30-day refill. There's obviously IV to PO protocols that we have in place too, where pharmacists can often make any of those changes without talking to a physician. It really just helps to make your workflow and your daily discussions with physicians, you can make them higher level because you can do a lot of things independently. In terms of patient teaching, we are able to discharge counsel, and we do discharge counsel every patient that heads home to manage their own medications. So keep that in mind too, that if you enjoy talking to patients, that discharge counseling piece ends up being a big chunk of your day. And one thing, you might wonder why advanced technician roles really impact you, but Advanced technician roles say that the way that we leverage technicians is probably one of the things that sets our department apart from others that are similar. So we have specialty trained technicians that complete medication histories that are then checked by a pharmacist. So there's a fairly robust workforce that's completing a lot of those medication histories. And there's also technicians that you can send electronic messages to through Epic that will check on insurance information on what medications cost. And that is really an indispensable tool. So you can help to create affordable plans for patients so they can get their medications when they leave the hospital, and it prevents a lot of the workaround that has to happen on the backside sometimes with patient goes to an outpatient pharmacy and realizes that a medication is not covered by their insurance and those kinds of things. And I really truly feel that here at UW we have that ownership of the medication use process. If there's something that's medication related, if we're not doing it, we're wondering if we should do it and trying to figure out a way to do it. Because I think the stance that we've taken as a pharmacy department is that we're really the best people to do medication management and really take a lot of pride in that. In terms of preceptor qualifications, if you looked at hospitals around the country, so again, we're looking kind of at that 400 to 600 plus, you'll see that we'll say around half at most have completed PGY1 training. If you're looking at those pharmacists, maybe up to a quarter have completed PGY2, and approximately, let's say 40% are board certified. So almost all of our pharmacists have completed a residency. I need to get the updated figure, but I believe it's 90 to 95% of our pharmacists have completed residency training. I don't know that you could get a job at UW Health now if you have not completed residency training, and those folks that have not have been here for so long that they're very much grandfathered in, and sometimes those have lots and lots of years of experience that equates to that level of residency training. We also made board certification required in 2018. So as you can see, our numbers were lower, and then they really ramped up, and we've had departmental funding that's helped people to do that, but we've made people practicing in clinical roles required to get board certified. So really all of your preceptors are going to be board certified, for the most part residency trained pharmacists, and in many cases PGY2 residency trained, especially within those specialty areas. In terms of the department overview, I think it's worth mentioning some of these specialized programs and services. Jack, I know, highlights some of these things in his talk as well, and that some of these things are in the tour, but really the thing for me to emphasize is the advanced clinical care that is provided here at UW Health. The Center for Clinical Knowledge Management is an interesting group that within especially your residency project here, you would have the opportunity to work with. So we call them CCKM. So they're an interdisciplinary team that evaluates and organizes the evidence to drive clinical decisions at UW Health. So what does this really mean? What this helps do is if a new drug product comes out, there's an interdisciplinary team that can then review which product is appropriate for use, rather than physicians deciding that potentially they're going to all switch to prescribing a certain new agent for their patients. This helps to make sure that interdisciplinary teams are on the same page when it comes to clinical practice guideline development, drug use policies, and delegation protocols. So I think this is a group that if you do have a project that has a clinical practice guideline that gets developed, or a delegation protocol that needs to be created, they're a group that you often would be working with, and they do have pharmacists on that team. So these slides are a little overwhelming. What these are screenshots of what one of our home screens within Epic looks like. This is a really fast way to navigate and look for various protocols and guidelines and things that we have in place. So let's say and I'll try to show you here, if you wanted to remember and pull up the guideline on whether you can switch something from IV to PO on your own without intervention of a physician, you could pull this route interchange adult protocol right here. It's a great circle that I just did. If you have a new drip order for a patient and you wanted to look at what our specific guidelines and recommendations are here, you could go here to this IV administration guideline. Pull that up. It's a UW Health specific tool. It's going to help make you feel better when you're verifying orders, especially as a new pharmacist, that you're falling within the scope of something that's appropriate. Same with electrolytes, enteral IV. I think that's another one that folks often end up pulling, and it can be really helpful. First time you get an IVIG order, you should pull up this IVIG specific medication guideline. There's even more. All of these are visible on that one screen, believe it or not, and really help you to understand what the scope of your practice is. They are all searchable on our internal server as well, so you can always do keyword searches if that's more how you work. But lots of different resources and things to help you make sure that you're making the right decisions for patients when you first start out as a new pharmacist. Some other things to keep in mind we're a residency program that's been around for a long time. We were established back in 1963, have greater than 400 alumni around the country, and really have a focus on innovation and try to be 5 years ahead of practice, technology, and research. Over here highlights some of the resident research projects that really have helped us to push that innovation forward. And if you were to ask our director, how do we do that? I think that Jack would definitely say that that has to do with resident research. And really our residents are the ones that push practice forward here at UW Health. So now I'll move into talking really why you're here, which is the PGY1 residency and what the specifics, what you would be signing up for if you opted to come to our program. So our statement of purpose is to provide an integrated pharmaceutical care at a patient-specific and population levels across the continuum. So what does that really mean? I think that means that we help to take care of the patient all the way from prevention to diagnosis to end-of-life care. We think about the wellness ambulatory environment all the way up through the, if you have a patient that needs to be in the critical care setting. I really like to emphasize the purpose. What I want to see you come out of a PGY1 with is that competence and competence to provide safe and efficient as well as cost-effective care for a patient. If you had to have two words that really resonate with you about what you would get out of coming out of our program, I think that that's what you would develop. I also feel confident that like I talked about before with the practice model, I think that you can take a skill set you learn at UW and take it to practice anywhere. In terms of the rotations, so you have 6 required rotations. So the required rotations, the 5 are here on the right, and then you could actually potentially make it just 5 required rotations if you elected to staff medicine in the second half of the year, because one of the things that we will have you do, and this came out of resident feedback, is you do have to have a rotation in the first half of the year that's in the area that you would transition to staffing into in the second half of the year. And really that's to help prepare you clinically and get to know that team and what those expectations are in the first half of the year to smooth the transition in January. In terms of elective rotations, so there's 4. You can also repeat any required rotation for more of an advanced elective rotation. I bolded some rotations here that have historically been really popular in the last couple of years. I'd say that almost everyone elects to do, and if you don't, I probably highly encourage you to consider doing a critical care rotation of some kind, as well as cardiology tends to be one that almost everyone chooses, and infectious diseases. We usually have almost everyone do that. I will not make you do a pediatrics rotation if you don't want to. We also have some pretty popular non-patient care rotations. Academia rotations are run by some of our faculty members at the University of Wisconsin School of Pharmacy, which is across the street. There's a connecting bridge that you can use to get over there. Some residents do elect to do informatics rotations, others pharmaceutical research center, but all of these are really options to you, and whether you would like to do those. In terms of your clinic rotations, so you'd have 2 different clinic rotations. All of the PGY1s do rotate through anticoagulation clinic, so usually it's about half in the first half of the year, half in the second half of the year, and then you get to pick an elective for the other the other clinic rotation. So lots of options here in terms of the type of clinic. Clinics are usually it's typically up to the clinic preceptor how they would like to have you, but it ends up being either a half day every week or a full day every other week on a consistent day for that half of the year. So it ends up being a pretty significant portion of your schedule, or about 10%, let's say, on each half of the year. So here's an example of what a rotation schedule might look like for a given resident. In the June-July timeframe, we do have a lot of training and orientation to get you ready to be a pharmacist and work within our system. You can see here that rotations are switched off monthly. You've got the our early commit deadline for PGY2s is November 1st. So really prioritizing that August, September, October rotation to make sure that you get exposure to whatever areas you think you need. I decided pretty late in the game of my PGY1 year, I think I squeezed in a November medicine rotation because I had a lot of different diverse interests. So I'm always willing to, if people need to switch things around, to try to figure out what type of PGY2 they need to do. That's something that very much resonates with me, and I'm always willing to help come up with plans if your original plan needs some adjustments. So we definitely have flexibility there, so we can help you out. Here you can see this particular example resident is staffing in neuro the first half of the year and is in the anticoag clinic. And then really in this late January timeframe is going to switch over to staffing in medicine and then doing an elective clinic, which we'll say they're going to do HIV clinic for their second half of the year. We do participate in the Great Lakes Residency Conference, which in years when we go in person is in West Lafayette, Indiana, and we do typically go in person. This year it will be held virtually. I'm hopeful by 2022 that it would be in person again. In May, we typically send residents on a practice development experience, which is the residency trip. And then one of the required rotations is precepting. So the precepting rotation, I think that's worth highlighting as well, is done in the clinical area that you staffed in the first half of the year. So if you, for this particular person, he or she staffed in neuro, so they would have a pharmacy student that they would be responsible for precepting somewhere in the second half of the year in neurology, and that tends to be a more teaching focused rotation, but is still considered a clinical rotation. Your practice development experience is staffing, so it's an average of 12 hours a week, which equates to every other weekend and 1 to 2 4-hour weekday evening shifts. You have the same role and accountability as a preceptor in those shifts that you would be covering. Residents reflect back that it's really the most valuable learning experience to both develop their confidence and competence, which were those two things that I highlighted as being the key outcomes of the program. You are supported, though, by, especially on the weekends, by what we call the weekend preceptor, which is a pharmacist that's taken offline to only support residents who are staffing. I think that this is especially important around those staffing transitions at the beginning of the year and also at the end of the year. They act as that safety net, often are coming in, checking on you in person, will sit with you wherever you're staffing and be able to provide feedback. They also write up a report for you to help you to develop to be a better frontline pharmacist. So really an indispensable resource, and there's some great folks that that work on our weekend preceptor team. Grill, or Grand Rounds Interactive Lunch and Learn, is our resident-led forum where patient cases are discussed on common clinical topics. All residents receive feedback to perform their clinical practice. It's a weekly lunchtime case-based active learning. So this happens on Tuesdays from 11:30 to 12:30, and each resident throughout the year gives one 45-minute presentation, and then all other residents are required to come and listen to that. You do get CE credit for participating in that, so it's also a great CV builder to put on your CV. Your major project. We do have all projects vetted through what we call our scholarship committee. Project list is provided to residents in early July. Residents submit their rankings to me, and then I do my best to pair up residents with their highest ranked projects. And it's kind of more of a kind of matching process. There's a little bit of time for residents to reach out to those project preceptors to learn more about the project as well before they have to submit their rankings. There's specific resident project advisors. A lot of our projects do focus on quality improvement and follow that focused PDCA model. I encourage you to look into that if that's something that interests you. All residents do present their poster at Vizient, which is the Saturday before mid-year, and do a podium presentation on their research at the Great Lakes Residency Conference. And by the end of the year, you have to present a manuscript that's suitable for publication. I would say that the research projects that we do here at UW are one of the things that sets our residency program apart from other programs. It's not just that our preceptors and the project advisors come up with ideas and then give them to the resident and they're like, this would be interesting, let's look into this. It's more that ideas are vetted as departmental priorities that have the potential to define our future practice and also potentially save money, take better care of patients, start a new service. They're things that are, I would argue, a little bit more practical than just clinically interesting. So I encourage you to talk with the residents and other folks that you meet about the types of research projects that are ongoing. The other thing that I think sets us apart is that you do get protected time with me, your program director. I have a weekly 1-hour lunchtime topic discussion, or sometimes we just get together and have lunch on Wednesdays at noon. There's also the opportunity to participate in the administrative residency seminar class, which happens around that same time. At those sessions, we have it broken up throughout the year to talk about these different practice topics, kind of more in an informal environment, which I think people enjoy. And we've also incorporated some journaling this past year where we journal on some ways to best take care of ourselves, reflect on experiences that we've had, and use that time to share out with each other. Some other activities that you would be doing, everybody gets ACLS certified, usually in July. There's an interdisciplinary mock code you would participate in. You can get involved in committees if you want. You can publish if you want. There's opportunities potentially for leadership, especially in some of these professional organizations. And that involvement in that organization is definitely encouraged. Folks that come here get lots of built-in advisors and mentors. So you get a residency advisor, so that tends to be your go-to person. Every year I get more people that apply to be advisors than I could possibly ever give to the 8 or 9 PGY1s that I have. You get me as an advisor, the major project advisor, you have rotation preceptors, the weekend preceptor, you have a longitudinal clinic preceptor. We do have 14 different residency programs here, so there's lots of PGY2 residents as well to help mentor you and help really guide you in the right direction. Lots of teaching opportunities at the UW School of Pharmacy, which is very close. The starred ones here are required experiences. That would be the precepting, rotation, and participation in pharmacotherapy lab, which is a full week where you're taken offline. You actually do that twice. You don't have clinical rotation at those times though. So either in the first half of the year or the second half of the year, you'll have 2 separate weeks where you are doing the teaching and pharmacotherapy lab. We do have a teaching certificate program that's run through the School of Pharmacy as well. I'm a course coordinator for that, and most of our residents do elect to do the teaching certificate. Lots of opportunities to precept APPE and IPPE students. You can do lecture-based teaching if that's something that interests you. There's usually opportunities to engage in that. We have a pharmacy internship program where you can mentor those folks. You can do an elective academia rotation, and then there's also School of Pharmacy mentorship programs that you can get involved in if you would like. Why consider us? So I think that I will let you all read through these reasons, but I think that there's lots of really good reasons. I would say that the reason I opted to come here for a job is really this number one. So this progressive and integrative practice site. I wanted to go to the place to learn how to do those transitions of care well. And a place that really took ownership of all of those important clinical time points, and feel that we do a really good job taking care of patients and setting them up to be successful. Some candidate attributes that are a good fit are listed here. I have 11 of them, so quite a few, and I will let you review those on your own as well, but lots of good positive things that I think that make people successful here at UW. So now we get into kind of some of the fun pictures and like what makes Madison fun, as well as some pictures of our residents having a good time. So here in the upper right, we have a map of Madison. So the hospital is located kind of near this isthmus, which when I first moved here, I had to look up what an isthmus was, but it's this land bridge that separates the 2 bigger lakes. Lots of water things to do, both in the summer and the winter here, because of all of the lakes that are around. So if that's something that interests you, we could definitely take advantage of that. The cheese curds here are very good. I personally prefer my cheese curds fried, and I'm told that the Craftsman cheese curds in Middleton are the best cheese curds of all. So I included a picture here for reference. The Dane County Farmers Market is really an awesome downtown farmers market that the largest producers only farmers market in the country. I'm really hopeful that it'll come back online this coming summer. There were some smaller farmers markets around that were able to still function during COVID last summer, but this is a really awesome place. For probably May through probably October, I get most of my produce at the Dane County Farmers Market. The zoo is really fun. So there's a free zoo that's very close to downtown Madison. It's probably only about 5 minutes from the hospital. What's cool about a free zoo is you can treat it somewhat like a public park, where you just pop in and go see the polar bears or the tiger or the orangutan on a day where you want to walk through. It's also open all days of the year. Even when it's snowy, there'll still be animals outside. The student union at UW is really seen as a gathering place for the community as a whole. There are places, once it gets a little warmer outside, if they maintain the structure that they've had, there'll be like reservations that you can make to still get even small groups together in this space as well. Here's a picture of downtown in the Capitol building. Babcock Hall ice cream is one of my favorites, especially the chocolate peanut butter. So that is made by the university. So definitely very good dairy things here in Madison. If you have some time, I encourage you to watch this video. It has some dramatic music with it as well. I won't play it for you right now, but a good intro to Madison where you can see some more like live images. So here's some pictures of fun from previous years that we've had. I do have a couple pictures of some fun from this past year as well. In the upper left, you've got some of our residents from last year at the terrace. They're outside having a good time. Here with the Ferris wheel, that's our, you got me and Dave here in the background. It's from our PGY1 resident exchange at the beginning of the year. The year before, we went to Cincinnati, where we meet with other residency programs. Here's a picture from the duck blind here with all these green hats in the lower left. That is I think it's not minor league baseball, but it's like a summer league baseball that is over on like the far east side of town, but they have a fun little area that it's like all you can eat, all you can drink once you pay to get into this certain area, and it's a very fun place to go hang out. And then here in the lower right, this is one of my favorite pictures, but these are the PGY1s from the previous year that all got together, and this is how they they went to a bar and put up a bunch of Post-it notes to figure out their PGY1 rotation schedule. And that's how we typically do it, is I give you a set of rules, and the PGY1s kind of duke out who's going to get rotations when, and believe it or not, it usually works out just fine. Here's a picture from the residents' Epic visit that they did in January 2020. So this was a fun event. You can see they have very fun carpet there at Epic. It's a very cool place if you ever have the opportunity to visit. Oh, and then we have this fun picture of me here at the bottom of the teeter-totter and Dave at the top of the teeter-totter. And this was from mid-year 2019 when we went to Vegas. So this was a very fun time when we had dinner together, and they happened to have this teeter-totter in the back behind where we had dinner. And these are some pictures from this year. So this year obviously was a little bit harder, but our residents were still able to get together in a safe, fun way. Everybody's very into, and I feel kind of in the know because I have some too, the Figs scrub pants. So here's some of our PGY1s that are in their Figs scrubs. Here's a really nice picture of Hannah and Philip with pumpkins from the fall. I'm pretty sure that Angie took these pictures because they're beautiful. Angie is this one here in the navy scrubs. She's one of our PGY1s as well and has a little bit of a graphic design background, so she has really helped to amp up some of the photos and things that we have in the department. Here's another fun photo of them. This is from when they went to I think there was maybe even a corn maze at this facility as well. But very cool. Lots of people still having fun, but in a safe way over this past year. And I'm hopeful that in the coming months and by the time you all would start, that things can get back to normal as well. So that's all I've got for you. I'm looking forward to meeting each of you one-on-one, answering some questions then. And hopefully this covered what you wanted to learn about the program. And as I mentioned, happy to answer any questions that you have.